everyone, and welcome to the third episode of our bi-weekly post-Ramadan quiz. This is a quick reminder of the case presented last episode. She's a 7-year-old presenting with bilateral microspherophakia and a tension of 32 and 34 millimeter mercury, accompanied with recurrent attacks of severe headaches. She had no cupping and was a moderate myope, correcting to 6.6. After a failed attempt to control her intraocular pressure with anti-glaucoma medications and cycloplegia, a bilateral surgical iridectomy was performed. Post-operatively, she reported complete relief of her headaches and occasional blurring that used to occur frequently prior to the surgery. Her IOP dropped instantly to 16 millimeter mercury the first week post-op, but started to rise again gradually to reach 25 millimeter mercury by the end of the first month. Anti-glaucoma treatment was added, and her intraocular pressure has been fluctuating between 18 and 21 on treatment for 3 years now. She has been followed up with OCT optic nerve head, showing stationary numeric values with normal retinal nerve fiber layer thickness. She is also performing specular microscopy annually for monitoring the endothelial cell density, which is stable. And most important, she's maintaining her 6.6 vision with stable refraction. My last comment about the use of cycloplegia is that it should be only administered if the zonules are intact to pull the lens posteriorly by tightening the zonular fibers and decreasing the anteroposterior lens diameter. If the zonules are not intact, dilating the pupil allows the lens to come forward into the anterior chamber, which might aggravate the pupillary block. We are all eager to listen to Dr. Chang's and Dr. Shakankiri's approach in this case. Thank you.
Hello, this is Ta-Chen Peter Chang, and it is a pleasure and an honor to be a part of the EPOS Ramadan quiz, and I would like to share my 2 cents in this EPOS commentary. So what do we do in the case presented by Dr. Dina? What we know so far is that the patient is a young child. She has good vision. She has high pressure but has not yet developed glaucoma. She has short eyes. She has unusual lenses, and both eyes are involved. And what is the goal of treatment here? It is, of course, to lower the eye pressure and to prevent the onset of glaucoma, but very importantly, we want to do so without making a mess. And what is the cause of the high pressure? Well, based on her history of intermittent headaches, it is most likely intermittent pupillary block. And related angle closure is most likely present. We do not know at this time whether she has developed significant synechiae. So to relieve pupillary block, all the classic options are available to us, namely medication, laser peripheral iridotomy, surgical peripheral iridotomy, or most aggressively lensectomy with peripheral iridotomy and gonial synechiolisis. Now, I'm a proponent of early lens surgery in pediatric angle closure patients in most cases. However, spherophakia is an exception because in my own experience, these lenses can be very difficult to deal with. Now, I understand my co-commentator, Dr. Nihal, is an expert pediatric cataract surgeon, and having reviewed her wonderful surgical videos, I would believe that she will be able to take much more leeway than I would dare to do. We should know that with increasing risk, there's also increasing benefits. So balancing the risks and benefit in this child, my comfort zone lies somewhere along these areas. So what I would do, I would start with a trial of medication, namely atropine for cycloplegia. I would do it first in one eye to see if this lowers pressure. It can be required up to 4 times a day administration to adequately control pressure. As mentioned before, this is most likely not a long-term solution, so we need to think about iridotomy. Now, the youngest patient who I have successfully performed laser iridotomy is 8.5 years of age. In the 7-year-old, we'll most likely have to do this surgically. And again, we can do this in one eye only, observe the eye carefully, and if the outcome is good, we can then do this to the other eye. If after surgical iridotomy the pressure remains high or if there's significant complication, then a lensectomy can be performed to relieve a pupillary block. Thank you very much.
Bismillah ar-Rahman ar-Rahim. This case presented by Dr. Dina, the microspherophakia, is quite challenging, presenting with low to moderate myopia, a vision of 6.6, and a healthy optic disc along the course of 4 years. She was actually managed meticulously and carefully and cautiously by Dr. Dina, and the child was fortunate, not developing complications until now. But this is not always the rule. The majority of cases I see in my practice, they usually present with a high lenticular sphericity, leading to a high myopia that is misdiagnosed as congenital myopia. And due to subluxation of the microspherophakia, they usually present with a high amblyogenic astigmatism that is not amenable to be corrected by glasses. Also, sight-threatening complications may occur as anterior dislocation of the lens, become cataractous and anteriorly dislocate, posterior dislocation of the lens, and if posteriorly dislocated, they may be accompanied by retinal tears. As in this photo, there is posterior dislocation and pigmentation in the vitreous, Scheffer's sign, indicating the presence of retinal tear and even start of PVR. They usually present with all types of glaucoma, secondary angle closure glaucoma when the lens subluxate. They usually present with pupillary block glaucoma. Unlike the case of Dr. Dina, peripheral iridectomy or even trabeculectomy as done in this case did not control the pressure because the primary cause is still there. They may present with a long-standing pupillary block glaucoma associated with iris atrophy or even very long-standing pupillary block glaucoma associated with ciliary staphyloma. It is common to present with both cataract and pupillary block glaucoma, and even they may present with total blindness. Here there is total loss of the anterior chamber, iridocorneal contact, and keratolenticular adhesion. So, the main line or the first line of treatment in these cases is lensectomy. Peripheral iridectomy will not prevent complications. I prefer to go for lensectomy through anterior approach, anterior rhexis, and then irrigation, aspiration, and eating up the bag with a cutter and performing localized anterior vitrectomy and closure of the two wounds by two sutures. Immediately after surgery, we see deepening of the anterior chamber. And these children are fitted with aphakic, ultra-thin, high-definition glasses, and you may use bifocal or multifocal glasses for near. And in cases where they did not develop glaucoma, we can use or we can implant secondary iris glow lens implantation in the future. Thank you.
Hello everybody, my name is Sahar El-Egeimy. I'm a fellow at Mike and I'm gonna present our case which we named it Look at the Behavior. My case is 4 years old child presented to our clinic at the Memorial Institute Kids Eye Center. Her mother was complaining of abnormal head posture since she was 1 year. Past medical history, there were intellectual disabilities and hypotonia. Past ophthalmic history was irrelevant. Family history was irrelevant, and there was a history of consanguinity of second-degree relatives. By inspection, there were some specific features like frontal bossing, arched eyebrows, depressed nasal bridge, and upturned nostrils. Ocular motility examination revealed no limitation of ocular motility, however, there was difficulty in initiation of the saccadic movement. And as regarding ocular alignment, she was orthophoric in 9 gazes for near and distance with no abnormal head posture. Let's have a look on this video demonstrating our case. As we notice, we are examining the ocular motility in different directional gazes. There is no limitation of horizontal movement, and also the vertical movement looks normal, and all other gazes looks normal. Now let's see how she will respond to the saccadic movement on the left side. Let's have a quick look on the cycloplegic refraction of both eyes. Anterior segment examination was normal in both eyes as well as posterior segment examination. We did the following investigations. We started with neuroimaging. An MRI brain showed a characteristic sign. Also, we did electrophysiology like flash VEP, which showed bilateral motor dysfunction of prechiasmal visual pathway, and also flash ERG, which showed bilateral moderate retinal dysfunction. We did both neurological consultation and genetic consultation. And now it's time for the quiz. Our first question is, what are the important signs in this case? A. Head thrust. B. Normal pursuit movement. C. Difficulty initiation of the saccade movement. D. All of the above. Our second question is, what is the most serious complication of this condition? A. Apnea. B. Renal failure. C. Ataxia. And D. Endocrinal disorders. Please wait for the answers of the quiz and commentators in the second episode, Professor Dr. Arif Khan and Dr. Mahmoud Yusri. Last but not least, I want to thank my mentor, Dr. Ayman Al-Ghunaimi, for helping me in preparing this case. Thanks for joining us. Ramadan Kareem.